Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by AGTC, Abbvie, Janssen, MeiraGTx, Novartis and Roche. We'd also like to thank Accessible Media Inc., our national media partner. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below.
So how today's session is going to work is I'm going to have each of our speakers give a short presentation about their research and what excites them in their field, and then we'll have questions from the audience. So our first speaker is Dr. Tina Felfelli. Dr. Felfelli is a resident physician at the Department of Ophthalmology and Vision Sciences at the University of Toronto. She completed her medical school training at U of T, where she received the J.P. Bowley Prize in Ophthalmology for the highest academic standing in her graduating class. Currently, she's completing her PhD degree in clinical epidemiology, and Dr. Felfelli received the Cecil Award in 2021 for her research into uveitis. Dr. Felfelli, over to you.
Thank you. It's a pleasure to be here today and talk about my research and get to know all of you. So my name is Tina Felfelli. I'm a resident physician in ophthalmology at University of Toronto. And I'm part of the Clinician-Scientist training program, which means that I like to marry the worlds of research and medicine into my practice. So in addition to seeing patients day to day in my practice, I hope to bring in research in order to improve the way we care for our patients, not only my patients, but patients globally and our patients in the future. Today I'm going to talk about a condition that I'm really passionate about. I think it's really important for us to know about it. And it's a particular disease that I'm doing my research on. This condition is actually one of the leading causes of blindness in young adults in developed countries. It affects patients that are really young and affects patients that are really old, but most commonly happens in patients between the ages of 20 to 60 years old. It has a prevalence between 30 to 200 per 100,000 people. And although it's less common than some of the most common conditions you may have heard about, such as diabetic retinopathy or diabetes-related eye disease, it really has a high burden in terms of the cost on the healthcare system, in terms of the burden on quality of life of patients. So what is this condition that I want to talk to you about today? It's uveitis. So the term uveitis comes from two concepts, uvea and itis. The term uvea comes from uva, which in Latin means grape. And it gets that name because it refers to highly vascular structures within the eye, the iris, the ciliary body, and choroid that have a grape-like appearance to them. In medicine, itis always refers to inflammation. So itis and uvea together make up uveitis, which means inflammation within the eye. Now, these inflammatory conditions within the eye can be due to a number of etiologies or diagnoses. In non-infectious uveitis in particular, the diagnoses may be due to autoimmune diseases that are ongoing, that are isolated within the eye, or may be part of a larger systemic condition. And these may be conditions you've already heard about or may have a loved one that's been affected by them. They include rheumatoid arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, psoriasis, lupus, Crohn's, ulcerative colitis, and the list goes on and on. So depending on where the inflammation happens within the eye, whether it's the front part of the eye, the middle part, the back of the eye, or the whole eye, patients will have different symptoms. And in some cases, they may have no symptoms at all. The patients that do have symptoms, they may present with redness, blurriness, pain in their eye, wavy lines that they may see, sensitivity to lights, spots in their vision. And again, some patients may have no symptoms at all. So what's really important is that we diagnose and treat uveitis effectively. And I'm just going to go back to the previous slide just to mention that on this slide I have a picture of myself. I have a photo of a picture of a patient with uveitis and a description of what uveitis is. So when we see patients with uveitis, as ophthalmologists, we want to promptly diagnose and treat uveitis, because if left untreated, uveitis can lead to permanent vision loss. So what do? We take a very thorough history of patients. We ask them about all their past medical history, the symptoms they may be having, medications they may be on, their risk factors, and really important questions about other systemic manifestations. Do they have any lesions on their skin? Do they have any abdominal pain, back pain, any joint pain, any difficulty breathing? And this gives us clues to what may be causing the uveitis. In addition, we do a very detailed eye examination. We may be doing images of their eyes. We may be doing images of other body parts, such as a chest x-ray. We'll do workup, blood workup, and sometimes we'll actually refer these patients to other specialists who will help us not only diagnose uveitis and the cause of the uveitis that they're experiencing, but help us with the treatment and management of these patients. Now, despite this comprehensive workup and investigation that we'll do for patients with uveitis, it's important to note that about 40% of patients with uveitis, we actually are not able to diagnose a specific cause for their condition. And in those cases, we call them idiopathic uveitis. The good news is that despite us being able to hone in on this specific diagnosis for uveitis, we have an array of treatment options that are available for uveitis and work quite effectively. These are cutting-edge medications that range anywhere from topical medications or drops that we administer within the eye, injections that we administer within the eye, and then systemic medications. So we can give patients oral treatments that they take, injections, infusions. And really what's exciting now is a new set of treatments that are available that are implantable treatments within the eye that provide sustained therapy to lower inflammation within the eye locally, that get rid of some of those adverse events that we see with systemic medications. So this is a really exciting new area with lots of medications being developed every year for patients with uveitis. Now, my research, which is something I want to talk to you about today, has two aspects. So one discipline of my research is focused on patients with uveitis as a whole, the patient population. So I ask questions such as, who are these patients? How old are they? What is their socioeconomic background? What are their barriers to accessing eye care services within Canada, within Ontario? How can we provide more cost-effective treatments for these patients? What is the cost to the healthcare system of taking care of these patients? How can we help their access to eye care providers? So these are big picture questions that are really important to answer to improve care to uveitis patients across the entire population. Now, the other discipline of my research that I think is equally important is looking at the individual level patient. So the patient as a whole and their unique characteristics. And this is the research that I'm doing right now, where we look at the inflammatory biomarkers unique to the patient population using advanced immunoassays that we have available currently, and advanced and sophisticated artificial intelligence methods to create a profile of patients' inflammatory biomarkers within their eye that is unique to them. And why is that important? Well, remember we talked about how uveitis is very difficult to diagnose, and sometimes we may not know the cause of uveitis. So this will help us have a better understanding of the pathophysiology behind what's driving their specific disease for that specific patient. It's also important because it helps us hone in on the specific treatment option for that patient that is most suitable for them. And that really decreases the trial and error process that usually goes into selecting treatments for patients. So it decreases the burden on patients, it fastens their recovery process, and hopefully prevents blindness from uveitis in that patient. So this is the part of the research that I'm really doing right now. I'm really excited about it. And I think it truly revolutionizes the way we treat patients with uveitis. And Finding Blindness Canada has been a big part of supporting the research that I do in this field. So overall, uveitis is a very important condition. It affects young adults in developed countries and is the leading cause of blindness in that patient population. Patients may have symptoms or may not have symptoms, so it's really important we diagnose and treat it promptly. There is a number of cutting-edge treatments that are available currently, and using personalized medicine, we're really able to change the way we treat this patient population, and my research is hoping to do that. So I thank Finding Blindness Canada for supporting my research and the work that I do, which I think is very important, and thank you for being here and supporting us.
Okay, thank you so much. So next up, we have Dr. Stefan Angton. Dr. Angton is an early career researcher and clinician scientist at Sunnybrook Health Center and Research Institute. He completed his MD-CM PhD joint program at McGill University with a PhD in neurological science, and then completed his residency at the University of Toronto and a 2-year clinical research fellowship in cornea at the Massachusetts Eye and Ear Harvard Medical School. Dr. Angton may be familiar to some of you as he was the winner of the Heathbridge Capital People's Choice Award last year at FBC's Eye on the Cure event, the same year that he was awarded the Cecil for his work in Fuchs endothelial corneal dystrophy. Dr. Angton?
All right, thank you very much for having me here. I don't have any slides today. I just think back of one of the best presentations that I saw and heard. It was by Dr. Bill Dixon, and he didn't use any sort of slides. So I thought I'd be just up here talking to you a little bit about my research, a little bit about myself, and kind of my perspective in terms of what I think is kind of the future of corneal disease treatments. So a little bit more about my background. So my name is Stefan Angton. I'm a clinician scientist over at Sunnybrook. My practice is really split up amongst seeing patients from a day-to-day perspective, patients with corneal diseases, and offering them surgical therapies for them. But it's also split up with running a basic science laboratory as well. So, you know, when I look back on, you know, why I chose to become a clinician scientist, it kind of started pretty early on in my training, and that's why I chose to do the combined medical school and PhD. And I think what's unique to a lot of us here as clinician scientists is that as being a clinician, we really have the ability to impact patients from a day-to-day from a day-to-day perspective of really treating patients. But we also have that bigger picture in mind where we can kind of come up with some discoveries and therapeutics that we can put in the hands of maybe all ophthalmologists, you know, throughout the world, where we can have a much broader impact. And I think, you know, throughout my training, I've kind of gone back and forth between, you know, the balance of how much clinical work and how much scientific work. But I'd like to provide you with a little bit of an anecdote where it really solidified, you know, my decision to become a clinician scientist. And it was during my fellowship, actually, where, you know, in the same day, I was able to see a patient with Fuchs dystrophy. We performed surgery on them. And then I was actually able to collect their patient tissue and actually take it to the research lab that same day to do same experiments. I thought that was pretty cool and kind of really solidified my, you know, it made me really, really kind of happy. And I think that's, you know, and it just reinforced the sort of passion that I had for this research. You know, so I think I've been, you know, as Morgan was saying, I've been very fortunate to be funded by Fighting Blindness Canada for 3 kind of separate projects. So I'm really excited about that. So I'll talk to you a little bit about, you know, so first we'll take a step back in terms of what the cornea is. So the cornea is the clear front part of the eye that allows us to see. And what I'm particularly interested in is the layer in the back of the cornea, which is composed of these specialized cells that basically remove fluid from the cornea and dehydrates the cornea so that it provides us with clear vision. And what disease that I'm particularly interested in is a disease called Fuchs dystrophy. It's actually the most common indication for corneal transplantation worldwide. And it affects about 4% of patients over the age of 40, actually. So it's actually fairly common. So, you know, I'll talk to you about a couple of the different funded projects that I have. So the first project is addressing sort of the genetic predisposition that patients have towards developing this disease. So we know that there's a genetic mutation that's affected in about 70% of patients that have this disease. So one of my projects is actually trying to come up with a therapeutic strategy to try to genetically remove this mutation and then potentially modify these cells so that we can potentially introduce these genetically modified cells as a therapy for patients. And it could be could follow in the footsteps of a lot of sort of genetic therapies. I think it's an exciting time in ophthalmology, particularly in inherited retinal diseases. So I hope that we can kind of lead the way for corneal diseases as well. The other project that I've been able to secure some funding for is to try to better characterize these specialized cells in the back of the cornea and the corneal endothelium. So this project is actually, what we're doing is we're collecting the cells from the corneal endothelium and looking at it in different spatial areas and trying to see if there's different cellular populations within the corneal endothelium. And we're using kind of the most state-of-the-art sort of technology to kind of analyze these cells and to look for their profiles and sort of behaviors that are specific, with the goal of having a better understanding of how these cells work and the different cell populations, that we can potentially uncover some novel avenues to develop therapeutics. And then a little bit one of these projects actually that I was able to get funding for through Eye of the Cure, and it's a little bit of a thinking outside the box. So I'll switch gears a little bit here and no longer talk about the corneal endothelium, but one of these, one of the projects is actually you think about. It was inspired by actually from my wife being pregnant, and one of the questions that arises is that, so when a mother is pregnant with a baby, they get half of the genetic material from the father. And one of the questions is that, why does the mother not reject the baby? Because half of it is kind of foreign to her. So that was kind of an interesting question. And through some collaborations at Sunnybrook, we're trying to identify, we've identified a molecule, a specialized molecule that plays an important part in this process called maternal phenol tolerance. And we're trying to develop it as a potential therapeutic for patients that have chemical injuries and get high-risk corneal transplantations. So, these ideas where you kind of think outside the box, it's hard to get funding for this. So having the funding from Eye on the Cure has actually been really good. And I'm actually really excited to kind of, I just came back from the American Academy of Ophthalmology, and we had put together a grant at the eye bank through the Eye Bank of America. And, we actually won the big award of about, which can further support this sort of research. So it just goes to show you how I think these grants can help, provide some pilot data to kind of continue the research, which is always it's a very challenging landscape now for funding. So I'll just end off with just saying that I think it's an exciting time to be a clinician scientist in ophthalmology. And that I'm really looking forward to kind of the future. And, part of, they asked me to kind of provide a little bit of, perspective in terms of what's coming for the future, for the research. And I think we're getting some excellent projects here that hopefully will be very meaningful and provide a large impact. So, I think, there's, just even coming back from this meeting, there was a lot of talk about treatments for dry, AMD, which, historically we haven't really had any treatments for. I think with gene therapy and Luxturna, it's very, exciting to be kind of here and to be an actual clinical therapeutic. And I think, a lot of work, I think has to be done in terms of trying to identify diseases kind of in the early stages so that we can actually prevent people from getting different forms of eye diseases. So I think that's really an important part of research going forward. Well, thank you very much for having me, and I'll happy to speak to you later.
Wonderful, thank you. Our next speaker is Dr. Marko Popovic. Dr. Popovic is a third-year resident physician in the Department of Ophthalmology and Vision Sciences at U of T. He's a Master of Public Health candidate in epidemiology at Harvard University. As a medical student, Marco was awarded with many awards for his contribution to research and dedication to ophthalmology. And Dr. Popovic is our most recent Cecil Award winner, just awarded this year for his research into retinal detachment.
Well, thank you so much, Morgan, for the kind introduction and for the opportunity to speak today. So I'm going to be speaking about a sight-threatening ocular emergency, which is retinal detachment. And I hope through a series of slides to let you know about some of the exciting work that has really been pioneered here and led here in Toronto, which we are sharing with the world and hopefully making real tangible change in the lives of patients with retinal detachment. So this is a clinical examination of a patient that we would see with retinal detachment. And before I go into this, I'll just give you a little bit of background information on what retinal detachment actually is. So the eye is held within there's a gel within the center of the eye called the vitreous, which with time liquefies and contracts and collapses in on itself and starts pulling on the back layer of the eye called the retina. When the vitreous starts pulling on the retina hard enough, what can happen is the formation of different types of retinal breaks or retinal tears. And the classic analogy that is often used is the wallpaper analogy, where the retina is like that wallpaper that you have, and with enough tugging, with enough pulling, tears or breaks can happen within that wallpaper. And what can happen is the vitreous gel, as it liquefies, it can get behind those tears, and those tears can continue to propagate further, and fluid can get behind those tears, leading to the formation of a retinal detachment. And as I said, this happens in emergency situations. So patients all of a sudden might develop a dark curtain or shadow, and if it's left untreated, leads to blindness in all cases. And so this is a photograph here showing exactly that process, where you have a retinal tear and then fluid coming behind the tear and leading to the formation of a retinal detachment. This is just another image just to show you a cross-section, a very detailed scan looking at a retinal detachment, whereby you see the retina here as the light and dark gray line here, and then below the retina you see this dark black space indicating the fluid has gone behind the retina and has detached the retina there. And so, we recognize that retinal detachment is an emergency and is something that should be treated right away. The question then becomes, how do we treat retinal detachment? And although there are three main methods of reattaching the retina, I'll just focus in on two main treatment modalities for today. The first is pneumatic retinopexy, and this is a minimally invasive clinic-based procedure where, in a period of about 10 or 15 minutes, you withdraw a little bit of fluid from the front part of the eye and inject a gas bubble into the back part of the eye, and that gas bubble acts as a tamponade, basically reattaching that wallpaper back into its natural configuration. So that can be done in the office or in the clinic, and could be done at all times of day. That's in comparison to the standard way of reattaching the retina, something called a vitrectomy, which is done in the operating room, involving a lot of significant time, resources, and effort in reattaching the retina. And I'll go into a little bit more detail about each one of these procedures and what we've learned about these procedures in terms of ways to reattach the retina. So I just want to highlight this landmark article that was actually published by the team here in Toronto, comparing these two methods of retinal detachment repair for certain cases of retinal detachment. And so this was a randomized trial, meaning that patients were randomly allocated to either receive the clinic-based procedure, the pneumatic retinopexy, or the operating room procedure, the vitrectomy. And so even though vitrectomy expends a lot more time, energy, resources in reattaching the retina, the question was, does it lead to better outcomes? And actually, in this study, they found that when you looked at patients over the course of follow-up, visual outcomes in the end were actually better with the simple clinic-based procedure, the pneumatic retinopexy, relative to the vitrectomy. And so the question then became, why are we seeing that? Why is the vision better with the simpler procedure? And so then a lot of research, again pioneered here in Toronto, was done to actually look at this and look at the underlying mechanism of how the retina reattaches and how that impacts the visual quality that patients have. And so I'll go into a few slides here just going over the process of these two procedures and why we think the vision might be, in certain cases, better with the simpler procedure. So this is the case of a pneumatic retinopexy here, where you see fluid has been already withdrawn from the eye and then a gas bubble is being injected into the eye. And so what happens here is that when the gas bubble goes against the retina, it basically acts like a plug to that retinal tear or retinal break. And what happens is the retina is detached from its underlying layer, and there's fluid in between those two layers. And with time, through a natural process, the body is allowed to reabsorb that fluid, and that gas bubble continues to push the retina back into its natural configuration. And with a little bit of time, the retina then becomes attached. Now, when you look at this at the cellular level, then the retina and its underlying layer, something called the retinal, like the RPE layer, those two layers are slowly allowed to come together and interdigitate in a proper configuration. You see here, as the two layers are coming together, they come together in a high integrity reattachment and are able to the cells are able to come together as they naturally would have been otherwise. Now let's take the case of vitrectomy, and there are slight variations in how this procedure is performed, but in a simple way, to explain it, not only is the gas bubble being injected and the body is allowed to kind of reabsorb that fluid from behind the retina, but also there's much more of an active process happening in the operating room-based procedure, the vitrectomy. And so what happens here is that during the procedure, an instrument is introduced inside of that retinal tear, and fluid is actively aspirated through that instrument to reattach the retina. And this happens much quicker than in the case of a pneumatic retinopexy. Well, we know that the procedures are different, but what are the implications on the retinal reattachment and the final visual outcomes? So you see here, as the retina is coming together in this much quicker process, what happens is some of the retinal cells from the retina and its underlying layer may not necessarily reattach in the same configuration that they were previously, and this in certain cases leads to a lower integrity of reattachment. And so we think that this is the reason that explains why, even with a simple clinic-based procedure, we're able to see better visual outcomes. Patients in general, what we're seeing are experiencing less distortion, less unequal sized images, and better visual quality with the pneumatic retinopexy procedure as opposed to the vitrectomy. So I just want to make a small comment about the study I'll be leading with the support of Fighting Blindness Canada. This is going to be a population-based analysis where we're going to look at retinal detachments done from patients in Ontario who have ever received retinal detachment surgery and compare these two procedures. We're going to be interested in looking at the complications of these procedures. We'll be looking at the long-term outcomes, so patients who've had these procedures for 5 or 10 years and seeing how well they did. And we'll also make a significant emphasis on looking at cost and seeing what the differences in cost are between these two procedures. And I really want to thank the support that we've received from Fighting Blindness Canada in order to conduct this important work. Thank you so much, everyone, for your time and attention today.
Wonderful, thank you. Okay, so last up, but certainly not least, we have Dr. Ellen Zhu. Dr. Zhu obtained her MD and PhD degrees at McGill University and is now a fourth-year ophthalmology resident here at the University of Toronto. Her research focuses on retinopathy of prematurity, a blinding eye disease that affects many premature babies. Dr. Zhu received the Cecil in 2020 for this work on ROP. And very exciting, I just learned that she will also be competing in this year's Eye on the Cure event. So we wish you the best of luck with that. It's very exciting. For anyone who's interested more in Eye on the Cure, please do visit us online at FBC-eyeonthecure.ca. You can watch the show live on November 18th for free. And if you do want to vote for this year's People Choice Award, you can make a donation of $50 to cast your vote. So definitely check that out if you're interested. I will certainly be watching and rooting for you on November 18th. So over to you, Dr. Zhu.
Good afternoon, everyone. Let me just bring up my slides. Hi, my name is Ellen Zhu. I'm a fourth-year resident at U of T, and in fact, Tina and Marco and I, we interviewed together. So Marco is also a PGY4. We interviewed together 4 years ago, and then it's very nice that we all got into U of T. And as co-residents, you share laughs and cry together. Sometimes you're like, I've seen 5 retinal detachment in a night. I've scraped 3 corneal ulcers together. So that's definitely the fun part of being co-residents together. So today I would like to talk about a disease called retinopathy of prematurity. I think it's not a disease that well known by the general public, and that's why I think it would be very interesting to talk about it. So as the name indicates, it's a retina disease of those babies who are born prematurely or born too early. So I would like to start my talk with a little story here. So last year, my research team and I received a very nice email from a patient. Let's call him Joe. Obviously, it's not his real name. So Joe said that, I'm a 40-year-old man who was born at 28 weeks. I had a lot of neonatal complications like necrotizing enterocolitis, bronchopulmonary dysplasia, as well as retinopathy of prematurity, ROP. Basically, he had severe problem of his intestine and lung, as well as the eye, and these problems are potentially life-threatening and blinding. And he continues to say that although a year as SickKids was extremely difficult for my parents, I'm grateful to have survived all these, apparently mostly untouched. I'm motivated to reach out to you guys because recently I developed a retinal tear, like a break in the retina, Marco just mentioned, which led to my ophthalmologist to say that he has never seen anyone with my age, my history, to have a retinal tear. This got me thinking about other health issues that may be on the horizon, and I learned that there's very few research on the scope of long-term complication of prematurity in adults. So in Joe's case, he was born in the early 1980s. Back at that time, the survival rate of premature infants at 28 weeks was only 20 to 25%. If you think that was low, these days, in the developing part of the world, survival rate of infants below 28 weeks was only 15 to 20%. So these kids had to fight really hard to stay alive, and their pediatricians have to work really hard to make sure they live as well. So then it is our job as ophthalmologists to make sure they see well and to enjoy the rest of their lives. And why do they need the care of ophthalmologists as a newborn? Because of this disease called retinopathy of prematurity, ROP. So as these babies are born early, their lungs are very premature and are not capable of providing enough oxygen. So to maintain their life, you will put these babies into an oxygenated incubator. And the oxygen here is a double-edged sword. For sure, it can sustain this baby's life. However, it can also cause uncontrolled blood vessel growth inside the eyes. And if these vessels are not treated, they can lead to bleeding inside the eyes and eventually blindness. So not every baby will, premature infants will have perfect vision. And here's an example of Stevie Wonder, who was born in the 1940s, 1950s, and he suffered from bilateral ROP, stage 5, and leading to blindness. And in fact, before the 1980s, we did not quite understand what causes ROP, and nor do we have very good treatment for the condition. Nowadays, since 1980s, we have several treatments, very nice treatments for ROP, and the blinding rate of ROP in these states are very low. However, there's a second part in our story is that Joe, at the age of 40, which is pretty young, developed a retinal tear, which is quite unusual. And when he told me that he had ROP as a kid, and I think that this retinal tear may have something to do with the fact that he had ROP before, and that led to the question, are there other long-term visual consequences related to ROP? And that's what my PhD thesis and current project hope to find out. So I did my MD PhD training at McGill. It's a combined training, same as Stefan. And my PhD was supervised by Dr. Sylvain Shimtop, who you met earlier and who's in the audience today. So together we use an animal model for ROP. We induce ROP in these little rat pups. They were babies, and then we follow them over time. Interestingly, as they reach mid-age, which is like 50 years equivalent of human age, they develop quite unusual retinal problems. For example, they have very few photoreceptors, so they have very little cells to detect the light. Their retinas are very thin, much thinner than the ones without ROP, and that translates into a much weaker visual function in the eyes. And that led us to think that ROP is not a static disease. We cannot say that we treated that problem and let's forget about it. No, it's a progressive condition that can precipitate long-term problems in our eyes. And it's very important for ophthalmologists to provide quality vision care to patients with ROP because the number of ROP patients had increased drastically in the last 3 to 4 decades. For example, in 1990, only 2% of premature infants had ROP, and that number jumped to 14% in 2021. And 10 years have passed, and I betcha the number has even been higher these days. And the reason for this increase is because we have better and better neonatal care. So more and more these premature infants can make it through. So we must obtain better understanding of the long-term impacts of ROP in these patients. And I would like to thank, of course, Finding Blinds Canada, who awarded me a very nice grant as a resident to pursue various research projects related to ROP. Right now, I'm working with Dr. Peter Curtis from Sunnybrook, as well as Dr. Kamit Miskandarai and Tarani from SickKids. We have other collaborators from pediatrics and ophthalmologists from Calgary and Montreal, and together we have a very nice team to pursue various questions related to the ROP. Thank you very much. Thank you for your time, and I'm very happy to take some questions.
Okay, do we have, Jamie, do you have a mic back there, or should we take one of these? Oh, you have one. Oh, no, like a microphone? Yeah, we'll take one. We'll take one and then, oh, we got one. Perfect. Got one. So I'm aware we're getting close to the end of the day, but we would love to take a couple questions if we have one.
My question is about retinal tears. Can it also cause internal bleeding besides blindness in the eye?
So not normally would retinal tears be associated with internal bleeding in the rest of the body. Yeah, they're typically if you have a retinal tear, the patient would typically see flashes or floaters, and it could actually be difficult to just based on the patient's experience to see whether there are going to be any retinal tears or no, which is why we tell patients if they start to see flashes and floaters, really important to come to the clinic to be checked to see if there are actually any retinal tears. In the case of a retinal detachment, as I spoke about earlier, that would be more of a curtain or a shadow, a dark curtain or a shadow that the patient would experience, and if untreated, that curtain would get larger and larger and larger until it involves the entire vision.
Thanks for answering my question.
I have a question. This is from a remote question from far away. If you have a torn retina and it's laser shut, what is the likelihood of it returning?
In the case of laser done for retinal tears, the chance of it reoccurring is actually fairly small. In patients who have this procedure done, overwhelmingly they will not have issues with that retinal tear again. Now, the thing to keep in mind though is that patients who have had retinal tears are at greater risk of having further retinal tears in the future in other areas. And so just because that one tear may be completely sealed off and likely won't cause any problems, it's still important to have regular eye checks done, especially if a patient has new symptoms in terms of flashes and floaters.
Thank you.
There's a question up at the front, Jamie. Oh, and then one in the middle. Yep.
Hi, this question is about corneal disease. Now, I have had a very unfortunate result from a cataract surgery 2 years ago, and it's left me with severe eye pain, like terrible burning. It's so severe that sometimes it's intolerable. And they and the symptoms are very similar to those that they consider to be symptoms of conventional dry eye, but none of the dry eye treatments that they have used on me, which are quite a few, like autologous tears, the PRP, amniotic membrane, all this kind of stuff, have not worked. And so they think, but they don't know, that it could be caused by peripheral neuropathic corneal pain. And as of the present time, from everything I've read and what they've told me, there doesn't seem to be any proven treatment for this, and I'm suffering. It's completely turned my life upside down. I can't work anymore because I really can't use a computer. I can't read I can read, I can see, and I'm driving and everything like that, but the pain is so severe that it prevents me from doing all these things. And I would like to know if there's any research being done right now on that.
Yeah, thank you for that question. I think pain of the eye and corneal pain, it could be multifactorial. It could be many different issues, associated with it. Depending on it's on a case by case. One of the things that could be contributing to the pain is that sometimes after cataract surgery, especially if it's a bit more complicated, what could happen is some of the cells, these corneal endothelial cells that are lining the inner lining of the cornea can become damaged, and there's a normal rate of decline of these endothelial cells as we all get older, but having some sort of procedure in the eye can sometimes precipitate that, and the result of that is that the cornea can become a little bit swollen. So it kind of depends in terms of what the underlying causes of the pain. With respect to your specific question about like a corneal neuropathy, or where it's really involving the nerves of the eye, it is an area that I think more and more recently that there is more research going into kind of understanding these corneal neuropathies, and where really there's been more and more evidence showing that there's a bit of an interplay between the health of these nerves and the overall health of the rest of the cornea. So, so to go back specific to your case, I mean, it kind of depends, in terms of there's certain clinical signs that we would have to look for, and you would have to get a specific eye exam. Then I can give you some more specific like advice about that. But in terms of corneal neuropathy now, there are a couple treatments out there, and it sounds like with part of it is addressing the ocular surface, dry eye disease, autologous serum tears, anti-inflammatories. There's also another medication that's out there. It's called the brand name. It's Synergermin. It's a recombinant nerve growth factor, and it's been shown in specific cases of corneal disease where the underlying cause is a neuropathy. That just topical application of this medication can help promote the growth of some of the nerves and help address some of the underlying causes. But there's been some challenges in getting it approved. It's actually, I think it is approved here in Canada, but the funding of it is actually quite expensive. So it's really hard to kind of get here in Canada, unfortunately. And then the other thing is that there is some evidence out there that treating this neuropathy with sort of oral medications, like in terms of what we call sort of to address sort of what's called a neuropathy, can have some effect as well. So.
Okay.
Mm-hmm.
So what medications are those, like gabapentin?
That is correct. Yeah.
Yeah, because you see that doesn't work on me. It doesn't work on everybody. So.
That is
the
true.
only other question I have is there even a way to diagnose whether this is what I have, because there don't seem to be any tests and nobody's really sure.
Right. So there is a way that is a diagnostic test that you can get. It's called confocal microscopy, where you use a specialized microscope to look at these nerve fibers within the cornea in a very detailed way. Unfortunately, it's, I'm not aware if in Ontario if we do have a confocal microscope. In the U.S. Where I trained, we did have one, and there are a couple centers in the U.S. Where we have it, but I'm not aware of any centers here in Ontario that have it, or maybe even in Canada.
Can you just repeat the name of that test?
It's called a confocal microscopy, in vivo confocal microscopy.
Okay.
Confocal microscopy. I'm happy to talk to you a little bit more after the session as well.
Yeah, we have one last question, and then we're going to have to wrap it up, unfortunately.
Okay, to your right, there's a microphone. There you go. To the first presenter, you had mentioned that there was personal medication, personalized healthcare, and I was wondering how accurate that is in terms of providing it to the patient. And then also you had mentioned that it's mostly within developed countries, and I was wondering what is the reason behind that?
Thank you so much for your question. So I'm going to start with the second part of your question, which was why we say it's the leading cause of blindness in developed countries and young adults. It's because there's a number of other conditions in developing countries, such as cataract, glaucoma, etc., that in developed countries we're actually able to treat very well. And so in developed countries, because we're able to address some of those more common conditions, uveitis becomes a more prevalent disease. In terms of the patient population, they usually tend to be younger patients in the working age group. And so there's been some associations in terms of various ethnicities, race of the patient population. So certain Turkish patient populations have a higher prevalence of certain types of uveitis. And different stressors and environmental factors have also been linked to uveitis, which may be unique to developed countries. In terms of the personalized treatment options that we're looking into right now, so we have a number of medications that are available for uveitis. So these may be, some of them are common conditions that treatments that you've heard about. So steroids that patients take, other medications that are a bit newer and work really well, such as biologics. And then we have alternative treatments such as biosimilars. So a lot of new medications that are coming out on a day-to-day basis. We have a set of guidelines that we follow for starting treatments for patients. So usually we start with steroids and we kind of work our way up to the more intensive immunomodulatory therapies for patients. What we're hoping right now is through our research to actually first understand the inflammatory biomarkers that are driving the disease. So first we have to understand that step better. And then once we have that understanding, we can identify what is actually driving the disease. So whether the specific molecules that are driving the disease, and each of the treatments that we have target a specific molecule. So we can select the proper treatment for patients that are intended for the specific molecule that's driving their disease, rather than going through that standardized guideline. And that really helps reduce the trial and error process. The stage of that right now is the research that we're conducting. So we're actually trying to first understand the biomarkers, identify those molecules that are important, and then within the next few years, our goal is to actually try different approaches to treating patients and initiating the personalized treatment options on patients, and then looking at the results and seeing how these patients do in the long term and what the burden of disease is on them versus a non-personalized approach. So I'm hoping that in the next 5 years, we'll actually have answers to some of these questions and be able to change how we approach treatment management for uveitis patients.
Well, thank you so much for answering all the questions and for being here today. It was really great to hear from all of you. And as a final reminder, thank you everyone for being here. Please fill out your surveys and drop them off at the door on your way out today. And again, thank you from everyone at Fighting Blindness Canada for being here and supporting Viewpoint.